So I'm very excited to talk to you about what's new in ART. Our learning, I have no disclosures. So our learning objectives for the evening will be to understand modern in vitro fertilization technologies and current controversies, to understand two specific topics that I want to address in more detail. One is the benefits and controversies surrounding fresh versus frozen embryo transfer. And the second is to understand the indications for pre-implantation genetic testing. So I understand that many of you practice fertilization on a regular basis, but for those of you less familiar, I just wanted to review. So we do a lot in IVF, and there are many components, but the things that are always the same, or that generally are the same in IVF, is that we have to stimulate the ovaries to grow a group of follicles. This occurs with a combination of follicle stimulating hormone or luteinizing hormone preparations, and generally lasts for approximately 7 to 12 days. We then perform a trigger, either HCG or GnRH agonist to trigger ovulation, and that is followed by an oocyte retrieval, which is generally performed transvaginally. We then culture the oocyte until fertilization. We can then fertilize the egg via conventional insemination or intracytoplasmic sperm injection, which is called ICSI. We then culture the embryo for 3 to 5 days. And we can then transfer the embryo immediately after culture, which is called a fresh transfer, or we can freeze the embryo for later transfer, which would be a frozen embryo transfer. And this is just a picture of our typical setup with a ultrasound guided transvaginal oocyte retrieval with the needle going into each ovary to retrieve the oocytes from the follicles, the follicular fluid being collected in a test tube and then placed in a petri dish for examination under a microscope to identify the oocytes for fertilization. This is showing a day 3 fresh transfer because we are transferring the embryo at the cleavage stage. As you'll see from my talk, current practice is moving away from this with either day 5 fresh transfer or frozen embryo transfer. So in general, who needs IVF? So originally IVF was developed for tubal factor infertility, but its uses have ballooned way beyond that. So patients with severe male factor infertility have significantly benefited from the introduction of ICSI. Anyone who's failed other fertility treatments, such as unexplained infertility, endometriosis, decreased ovarian reserve, or recurrent pregnancy loss, often benefit from IVF. Or patients with known genetic mutations who want to avoid passing on those mutations to a child. And increasingly, we're seeing IVF used for fertility preservation, either of oocytes or embryos. So what's new in ART? I'd be very curious to hear what the trends are in Egyptian practice, but this is what's going on in US practice right now. So first of all, day 5 blastocyst culture. So we do have the option of transferring embryos on either day 3 or day 5. In theory, embryos could be transferred on day 2. That's how the original IVF baby was born too. But for embryo selection, usually day 3 or day 5 is what we prefer. Most US practices are moving towards day 5 blastocyst culture because conditions in the lab are being optimized to allow for better blastocyst culture, and embryo selection is better at the blastocyst stage. So because our goals have shifted in IVF to better embryo selection, day 5 blastocyst culture allows us this option. Now, day 5 blastocyst culture also allows for day 5 blastocyst freezing, and embryos do tend to survive the thaw better on day 5 as well. So there are definitely still places, UH included, where we do some day 3 transfers. There are many practices that have moved exclusively to day 5 blastocyst culture. There's also an increased utilization of ICSI, or intracytoplasmic sperm injection, where the sperm is chosen singly and directed directly into the egg, versus conventional insemination, where the sperm are placed around the egg and allowed to fertilize naturally. There are some centers in the US that are doing ICSI for all patients. Others use ICSI selectively, only for specific indications such as male factor infertility. So this varies by site. So there are some places that use ICSI anytime they're doing pre-implantation genetic testing, or Pgta. I would say that's the vast majority. Other places don't. But because of trends towards increasing use of Pgta, as well as increasing use of ICSI for both male factor and unexplained, there is an increasing use of ICSI generally in the United States. There's also an increased use of GnRH antagonist protocols. So the traditional protocols for IVF relied on the use of GnRH agonists for downregulation. However, there is a move to decrease ovarian hyperstimulation syndrome in IVF. So because of that, many cycles are preferentially using GnRH antagonist cycles for stimulation, which allows for the use of GnRH agonist triggers, which significantly decrease the risk of OHSS. Now, I would not say that most centers use GnRH antagonist cycles exclusively, because there are many advantages to GnRH agonist stimulation protocols, microdose flare protocols, and other combinations. But I would say that many centers are relying more heavily on GnRH antagonist protocols as their first-line protocol, especially in high responder patients where concern for OHSS is larger. So there's also a trend towards freeze-all in these cycles. So in general, if there's a concern for OHSS, using a GnRH antagonist with a GnRH agonist trigger, there is an overall trend towards freeze-all in these cycles without a fresh transfer. So whenever we use a GnRH agonist trigger, trending towards using a freeze-all approach. And in general, using a GnRH antagonist cycle with a Lupron trigger is usually recommended for patients at high risk of OHSS. These would be patients with PCOS who have a high baseline AMH, or other patients who are at risk for OHSS because of other factors. What else is new? Pgta, and we're going to talk about this in a lot of detail. So the trends in Pgta are blastocyst biopsy with next generation sequencing. So what does this mean? You know, in the past, we would often biopsy embryos on day 3 of development, and there were many technologies available for Pgta analysis. There was CGH, SNP arrays, PCR. So right now the trend is to biopsy embryos at the day 5 stage, so blastocyst biopsy, and most Pgta companies in the United States are using next generation sequencing for their Pgta analysis. Now, the question is, should Pgta be applied selectively or universally? And that is an area of controversy that we're going to discuss. I would say that most academic centers in the United States use Pgta selectively. In other words, they counsel patients that Pgta is not indicated unless there are specific reasons that they need Pgta. I would say many private practices in the United States, and this depends on regional distribution, have moved towards more of a universal use, meaning recommending Pgta for all patients. But this really varies by region within the United States and private versus academic practice. So this is definitely not something that is universal practice within the United States, but there is an increasing usage of Pgta, but whether it's selective or universal use is a matter of debate. A major trend in IVF in the United States is elective single embryo transfer. So there's a big push to reduce the number of multiple gestations within IVF, and that is a major goal of the American Society for Reproductive Medicine. So that is something that, you know, ASRM has created guidelines for, to reduce the number of multiple gestations by recommending that patients reduce the number of embryos they have transferred. And overall, the goal is that for young women under the age of 30 or 37 or below, the recommendation is to transfer 1 embryo, especially in the first cycle. For older women, you know, the recommendations are still to transfer more. However, one of the reasons why Pgta has become more popular is to push towards elective single embryo transfer. So that would say that is one of the major trends in US practice, is to go more towards elective single embryo transfer to reduce multiple gestations in IVF. and the routine use of freeze-all in certain centers. So, we're going to talk a lot about fresh versus frozen embryo transfer, but there is a trend in the United States to freeze all in more circumstances. And there are some centers that don't do fresh transfers anymore. So there are some places where you cannot get a fresh transfer if you do IVF. I would not say this is the norm. This is not typical. A lot, UH where I practice, we still do a lot of fresh transfers. A lot of places still do, but there is an overall trend in US practice towards more freeze-all cycles. And finally, and I alluded to this before, there's increased utilization of oocyte cryopreservation. So many women are choosing to defer fertility, and in order to have the option of getting pregnant later, they want to electively cryopreserve their oocytes. So there are many women who are freezing their eggs for later use. In the past, this was mostly for cancer patients. Now this is for many women who are doing this electively for age, for other reasons why they want to defer fertility. So oocyte cryopreservation is a very new, but also very common practice now among IVF centers. And there are even a couple practices that have developed in the United States specifically for the indication of egg freezing. In other words, there are practices that devote their entire practice to elective egg freezing. So what's new in IVF for third party? So I alluded to it before, but because egg freezing has become more commonplace, there is a whole industry that has developed in the United States for frozen donor eggs. So there are egg banks now that have been developed where women who want to be egg donors will go through an IVF cycle and then freeze their eggs. And then the egg bank can then distribute those eggs to women who want to use donor eggs. So women who want to use donor egg can still do a fresh donor cycle with a donor going through and take all those eggs from the cycle, or they can purchase eggs that have been previously frozen from a donor. And then the centers will, take a donor that, has 24 eggs, they might then take 8 eggs into batches and give those eggs to different patients. So that's a new phenomenon. There are obviously donor sperm banks as well. And then gestational carrier is legal in the United States, but the laws vary by state. So some states don't allow paid gestational carriers, some do. So it really varies by state in terms of the legality of paid gestational carrier, but the laws are much more permissive than in other countries. So that's a little bit of an update about what's happening in the United States and IVF. Let's talk about the current controversies that I wanted to talk about today. So the two things that I wanted to discuss are fresh versus frozen embryo transfer and what is the role in neonatal outcomes. And a very brand new issue is programmed versus natural cycle for frozen embryo transfer. We're beginning to see data that doing a hormonally programmed frozen embryo transfer cycle may be associated with adverse neonatal outcomes, and we may look for alternate protocols for frozen embryo transfer for the improvement of neonatal outcomes. We also want to talk about when to use Pgta for embryo selection. So let's start with fresh versus frozen embryo transfer. So as we said, embryos can be transferred in the same cycle as the retrieval, 3 to 5 days in culture. That's called a fresh embryo transfer, or they can be frozen in later cycles. Now, freezing right now is accomplished via vitrification, which is rapid freezing in liquid nitrogen to prevent ice crystal formation. And as we said, embryos are typically frozen at the blastocyst stage. They can be frozen at the cleavage stage as well. Now, there is data to suggest differences in pregnancy outcomes between fresh and frozen transfer, and this is likely due to differences in the hormonal environment during the fresh transfer, although we cannot exclude impact of the freezing process on the embryo. The epidemiologic data points more towards differences in the hormonal environment as being responsible for the differences in neonatal outcomes. So which is better? Fresh or frozen embryo transfer? I don't know that we have the answer, but I will talk you through the data that we have, and then hopefully you guys make the decision for yourselves. So one thing that we have seen is that superovulation, meaning all the hormones that we use in IVF, appears to have an effect on implantation and fetal outcome. So gonadotropin stimulation, which leads to elevated estradiol during oocyte development, has an impact on the endometrium. This seems to be connected to weight and growth changes of the resulting pregnancy, probably because of changes to the endometrium that affect embryo implantation and early placental development. By doing a frozen embryo transfer, we can prevent this impact and alter the endometrial environment at the time of implantation. And epidemiologic data do suggest differences in birth weight between fresh and frozen IVF. Specifically, we see higher rates of low birth weight and small for gestational age following fresh IVF. Now, in the past, we used to say, oh, this is only because of multiples. How do you know that this is also true in singletons? But in analysis restricted to singleton gestation, this is still true. So low birth weight is still prevalent in increasingly significant numbers after fresh transfer compared to frozen transfer. Now, one of my former colleagues at the University of Pennsylvania performed a very nice study that isolated the endometrial environment as being responsible for this and not the freezing process. This was in 2011. And what she did was she used SART data, which is our national registry data in the United States, and looked at the odds ratio of having a low birth weight baby following fresh IVF. And what she found is that the overall risk of low birth weight and the risk of term low birth weight were both higher after fresh transfer compared to frozen transfer. Now, the interesting thing in this study was that she also looked at a subset of women who used donor egg IVF. So in those women, whether they used a fresh embryo or a frozen embryo, the endometrial preparation was the same. And in those cycles, there was no difference in birth weight between fresh and frozen embryo transfer. So this study was very elegant and suggested that the fresh environment following IVF with all of the hormones after the fresh transfer was the etiologic mechanism for small for gestational age, not the freezing process itself. Now, this has been found in multiple other observational trials. So fresh embryo transfer has been associated with lower birth weight. It also seems to be associated with the higher estradiol levels. So in other words, if you have a low response to the stimulation, you may not see this effect as much, but if you have very high estradiol levels, that seems to be associated with a higher chance of small for gestational age and a higher rate of preeclampsia. Additionally, fresh transfer is associated with a higher rate of ovarian hyperstimulation syndrome. So the question is, observational studies are very nice, but what about randomized controlled trials? So that's where these two studies that were published in the New England Journal of Medicine, which is one of the top journals in the United States, came into play. So there were two studies that were performed in China that randomized women to fresh or frozen embryo transfer. One was published in 2016 and looked specifically at women with polycystic ovary syndrome or PCOS. The other was published in 2018 and looked at women without PCOS. And what they did is randomize women who are going through IVF to either receive a fresh embryo transfer or to freeze all their embryos and receive a frozen embryo transfer. What they found was that in both studies, there were differences in birth weight. So they found decreased birth weight in the fresh group compared to the frozen group. In the 2016 study, the difference was about 200 grams. In the 2018 study, it was similar. The 2018 study also found a higher rate of small for gestational age in the fresh transfer group. The live birth rate, interestingly, was higher in the frozen transfer group among women with PCOS, but was not different among women without PCOS. So based on all of this, we can conclude that fresh embryo transfer is associated with higher rates of small for gestational age infants. And frozen transfer is associated with higher success in the randomized control trial in PCOS patients. Frozen embryo transfer is also associated with lower rates of ovarian hyperstimulation. So, should we perform freeze-all cycles for all of our patients? This data would seem to suggest that small for gestational age, which is a risk, OHSS is a risk, can all be prevented by doing freeze-all cycles. I wish it were that simple. Because if you go back to the randomized control trials, the results also show risks from the frozen embryo transfers. So even though both studies showed a decrease in birth weight in the fresh groups, the analysis from 2016, they went back and did a secondary analysis, showed an increase in large for gestational age in the frozen embryo transfer group. Additionally, they found a higher rate of preeclampsia in the frozen embryo transfer group. So this was in 2016. And that was a hint that something was different in frozen embryo transfers than we thought. And the observational trials also seem to suggest that there was a higher rate of large for gestational age babies in the frozen group. I'm not sure anyone was paying so much attention to that until the randomized controlled trials, and especially the higher rate of preeclampsia. Then people started paying attention and started to ask why. So, multiple observational trials were done and also demonstrated higher rates of large for gestational age and higher rates of preeclampsia in frozen embryo transfer cycles. Now, people have started to look at specifically what aspects of the frozen embryo transfer are associated with these risks. Is it the freezing process, like I discussed before? Is it something that we do in the frozen cycle? Now, most people in the US, and you can tell me this is done in Egypt, do their frozen cycles via programmed cycle, which means that we don't let the woman ovulate. We give replacement of estrogen and progesterone and transfer the embryo time that way with an absent corpus luteum. So estrogen and progesterone, well, estrogen suppresses ovulation, and then the progesterone prepares the endometrium to be receptive. There is some question about whether the absence of the corpus luteum and the ratio of estrogen to progesterone may be the etiologic mechanism for these risks. Other types of frozen cycles are natural frozen cycle, where the embryo transfer is timed to natural ovulation, or a stimulated frozen cycle, where ovulation is induced with gonadotropins like FSH, or with other medications like letrozole to induce ovulation, and then the transfer is timed to the woman's natural ovulation. So there's actually been several studies now that have tied the risks of large for gestational age and preeclampsia specifically to programmed frozen cycles, meaning cycles in which estrogen and progesterone are used exclusively to prepare the uterus for transfer. When these cycles are compared to women who use natural or stimulated frozen embryo transfer cycles, they do not see these risks of large for gestational age and preeclampsia. So that begins to ask the question, is it really just a factor of the hormonal environment? And are we creating a synthetic hormonal environment with our frozen embryo transfer cycles that is actually creating a different problem? So we're solving our small for gestational age problem by not doing a fresh transfer, but maybe we're creating a new problem by altering endometrial embryo interaction that is actually leading to a different growth problem and an increased risk for hypertensive disorders of pregnancy. So this was a study that was just recently published. Actually, this was 2019. Sorry, there's other studies that have just been recently published that have also found similar results that looked at neonatal and maternal outcome after frozen embryo transfer and found increased risks specifically in programmed FET cycles. So this was a large study, which is why I included it for you to look at. So it was a retrospective study of 9,726 singleton pregnancies, and they compared outcome by type of endometrial preparation. And what they found was that programmed cycles were associated with a higher risk of hypertensive disorders of pregnancies, post-term pregnancies, and macrosomia. So what conclusions can we draw? So fresh transfer is clearly associated with a higher risk of small for gestational age, a higher risk of preeclampsia, and that seems to be with higher estradiol levels. So the higher the response, the higher the risk, and a higher rate of OHSS. Frozen transfers are associated with a higher risk of large for gestational age, a higher risk of preeclampsia in programmed FET cycles, and a lower risk of OHSS. So what's our take-home message? Well, success rates are likely better in frozen embryo transfers for some, but not all patients. And therefore, we recommend freeze-all for patients that have a high estradiol level, who are at risk for OHSS. And we also see patients that have an elevated progesterone level on the day of transfer have lower success rates with fresh transfer. However, we are hesitant to recommend freeze-all for everyone until we have more information about optimizing neonatal outcomes in frozen embryo transfers. And we do not know yet what the best way is to prepare the uterus for a frozen embryo transfer. I'm hesitant to recommend natural or simulated frozen embryo transfer cycles yet, universally, because we don't have randomized controlled data. And we don't know that observational studies are necessarily going to be confirmed by randomized controlled trials. We always learn something new when we do randomized controlled trials, but there are many centers in the United States that are doing more natural and stimulated frozen embryo transfer cycles to decrease preeclampsia risks. There are trials underway, and so hopefully we will have more data soon to recommend best practices for frozen embryo transfers. Now, one of the big challenges of this is that for scheduling in the lab, programmed frozen embryo transfers are much easier. They allow a lot more flexibility. They avoid weekends. They allow, a physician to know that they can be available the day of the transfer. So, natural or stimulated frozen transfers are not easy. So many centers are grappling with trying to optimize patient outcomes, but also trying to optimize lab staffing and physician staffing. So we do not have the answer yet for this, but this is where we are currently in the debate about fresh versus frozen embryo transfer and optimizing protocols for our frozen embryo transfers. So with that, I would like to move on to our controversy number 2, pre-implantation genetic testing. So pre-implantation genetic testing is becoming more common, but we still don't know when should it be used and does it improve patient outcomes. So let me first explain the difference between Pgtm and Pgta. So Pgtm, what used to be called Pgd, is pre-implantation genetic testing for specific gene mutations. So we can test for a single gene mutation in a pre-implantation embryo, and it's important for couples who have a known risk of transmitting a genetic disease to their child. For example, these would include cystic fibrosis or spinal muscular atrophy. Pgta, which used to be called Pgts or PGS, pre-implantation genetic screening. All the letters have changed in recent years. Test the embryo for aneuploidy or euploidy without a known history of a genetic issue. So this is used to increase pregnancy rates in couples with an increased risk of aneuploidy. For example, people who have advanced maternal age, recurrent pregnancy loss, or repeat implantation failure. It's also being used now routinely for embryo selection, and it can help increase rates of single embryo transfer. There is also something called PGTXR, which is used for patients who have a known balanced translocation, where the Pgt company can select embryos that are either euploid or balanced for that translocation. Now, embryo biopsy, as we discussed, can be performed either on day 3 of a single blastomere or on day 5, which is increasingly common, of trophectoderm cells. So on day 5, multiple cells are removed for the trophectoderm, whereas on day 3, only a single cell is removed. The trend in the United States is overwhelmingly to perform day 5 blastocyst biopsy, and this is because of decreased damage to the embryo compared to day 3 biopsy. There have been studies showing increased implantation rates of day 5 biopsies compared to day 3 biopsies, and there's a higher rate of accuracy due to more cells biopsied, 8 to 10 cells rather than the 1 cell with a blastomere biopsy. And finally, less chance of embryo self-correction compared to day 3 biopsy because you waited until the day 5 of biopsy as opposed to day 3 when the embryo has more chance of excluding cells that are genetically abnormal. Here is a video that shows what a trophectoderm biopsy looks like. So this red is the laser. So you can see the laser making a hole in the zona pellucida. And then the pipette comes in to take the trophectoderm cells. There are 2 techniques for blastocyst biopsy. So this one you can see they're making the laser on day 5. Some other cells will actually assisted hatch the embryo on day 3, allow the cells to herniate, and then take the cells on day 5 once they've already herniated through the zona. There is some interesting data suggesting there may be differences in mosaicism based on those rates or differences in success. But this is a very common technique that I showed you where the hole in the zona is made with the laser at the time of biopsy. So this is an overview of Pgta. So you take the eggs, fertilize them, usually by ICSI, blastocyst biopsy on day 5 by taking the trophectoderm cells, and then wait for the Pgt results prior to transfer. So I want to talk a little bit about Pgta technologies and then some of the controversies surrounding when to use them. So first of all, what technologies are available for Pgta? So in the past, we used FISH, then it progressed to CGH and SNP-based microarray. There was a physician in the US who developed qPCR-based based PGT. And now, like we talked about, next generation sequencing. So FISH was a historical method that really is not used today, but that was the traditional method used for the original version of what was then called PGD. Now we do comprehensive chromosome screening, or CCS, which is a method that evaluates all 24 chromosomes. Options include CGH, which is an array-based technology, SNP, which is also an array, but adds more accuracy to CGH, qPCR-based screening, which was developed as a simpler technique that does qPCR on segments of all 24 chromosomes, and then next generation sequencing, which actually sequences all the genes and provides a much more accurate assessment of the chromosomes. So next generation sequencing, we're going to be talking about in a lot more detail because that is what we use today. I'm sorry, I should say 23 chromosomes, not 24, I apologize. All right, so CGH versus SNP versus PCR versus next generation sequencing. All right, so let's talk about all the different technologies. So first of all, CGH, SNP, PCR, and next generation sequencing can all detect aneuploidy. So they can detect trisomy and monosomy. So trisomy is obviously when we have an extra chromosome, monosomy when we are missing a chromosome. So that is the benefit of all of these technologies. However, one of the downsides of CGH is that it cannot detect triploidy. For example, if there's an extra set of all chromosomes. However, SNP can, PCR, which was developed to be very simple and cheap, cannot, but next generation sequencing can. Now, some of the downfalls of Pgta is accuracy, and one of the issues is something called whole genome amplification. So whole genome amplification requires amplification of the DNA, and then there is an issue when you have to amplify the DNA of something called allele dropout. So if you amplify the DNA and then you're missing some of the alleles because during your amplification process, then you may have less accuracy than you would actually expect. So anytime you have to do whole genome amplification, you might decrease the accuracy of your PGT technology. So one of the benefits of this qPCR was that it did not require whole genome amplification. Now, next generation sequencing, depending on how it's run, may or may not require that. The time required for CGH was not that complex. SNP was more complex. The qPCR was developed to be much simpler. Next generation sequencing was extremely complicated. The reason we can use it now is that it's becoming much less complicated. And that's why the complexity cost was rated at medium, but it's becoming much simpler as it's just becoming more widespread. So is Pgta effective for improving clinical outcomes? That's the big question. So let's take a little history tour of Pgta, and then we can come to modern day. So I don't know how many of you were practicing in 2007, but if you were, you will remember the first iteration of Pgta. And you will also remember that Pgta kind of went up, and then it went down, and then went up again. And one of the reasons was that even though we all expected Pgta, or at the time it was called Pgd, to be effective in improving clinical outcomes, it did not. And this randomized controlled trial, which was published in 2007, epitomized the problems with I'll call it Pgd because that was what it was called then, Pgd in that iteration. So this was a trial that was published in 2007 that was a randomized controlled trial of PGS for AMA. And they randomized 408 women ages 35 to 41 for day 3 biopsy with 8 probe FISH versus no PGS. And their primary outcome was ongoing pregnancy at 12 weeks. Now, what they found was actually no difference in pregnancy rates in the PGS group and the control group. It was not significant, but the pregnancy rate was actually lower in the PGS compared to the control group. So the conclusion was that PGS did not increase and may in fact have decreased pregnancy and live birth rates in women over the age of 35. So the question then was, why did PGS fail to show an improvement in pregnancy outcomes? And the answers that came out over the years were, well, we think it may have been due to day 3 versus day 5 biopsy and the technology at the time, which was FISH versus our modern technology of CCS. So in current practice, a lot has changed, right? Now we biopsy embryos on day 5 of development, and we test all of the chromosomes. So in theory, our testing should be a lot more accurate, and our Pgta technology should improve pregnancy outcomes. Well, in 2013, Richard Scott and his group in New Jersey did publish this randomized controlled trial, which did show improved pregnancy outcomes in patients undergoing Pgta. So this is a randomized controlled trial. They did Trophectoderm Biopsy, so day 5 biopsy, with this qPCR-based PGS technology. So in other words, they were doing the qPCR where they just did PCR on a little segment of each chromosome, and they also did fresh transfer. So they included good prognosis women, so ages 21 to 42, and their outcome measure was sustained implantation rate, which was, they defined it as a live birth rate per transferred embryo. And their secondary outcomes were implantation rate, clinical pregnancy, and live birth. And what they did was they did routine care until day 5 of embryo culture, and then they randomized the patient if they had at least 2 blastocysts of adequate morphology for trophectoderm biopsy. And then they were randomized to either PGT or no PGT. Now the PGT group had trophectoderm biopsy on day 5, and they did this with a qPCR technology, and they transferred up to 2 euploid blasts on day 6, because at the time they could do 24-hour turnover. The control group had no biopsy, routine morphologic assessment, and they transferred 2 blasts on day 5. So what they found was the live birth rate, first of all, was very high in this group. So keep that in mind. It was a very good prognosis group overall. They all had at least 2 blasts apiece. It was 85% in the PGT group and 67% in the control group. So that difference was statistically significant. So their conclusions were that Pgta with day 5 biopsy and qPCR-based analysis did improve pregnancy and delivery rates in a population without decreased ovarian reserve. Now, this study had a lot of limitations. Only good prognosis patients with good morphology embryos were included. I think since then, we've also learned some other limitations. It was this qPCR-based technology, and it was a single center that happened to be very good at doing Pgt biopsies. Now, other randomized controlled trials seem to indicate a approximately 60 to 70% ongoing pregnancy rate with transfer of a euploid blastocyst. So all of that looked very promising. But once people started to look at real world data, then they started to have doubts. So this is a study from 2016 that started to raise some of those questions. So this is a study out of Cornell that was a case-controlled trial of 274 Pgt cycles and 863 non-Pgt cycles. What they found was that there was no benefit of Pgta in patients less than 37 years old, and there was improvement in patients over 37 years old if you look at it on a per transfer basis. But if you look at it on a per retrieval basis, they did not show any benefit. So in other words, the study that we saw, that was a randomized controlled trial, it showed an improvement of outcomes when patients had at least 2 good quality blastocysts to biopsy. But when you're sitting there with a patient, talking to them about whether they should do Pgta or not, you don't know whether they're going to have 2 good quality blastocysts to biopsy or not, because you don't know what's going to happen to their cycle. You don't know if they're going to stimulate well. You don't know how many eggs they're going to get. You don't know how many are going to fertilize. And then you don't know how many blastocysts they're going to get. So you have to counsel the patient prior to them choosing Pgta before you know how many eggs they're going to have, how many embryos they're going to have. You counsel them per retrieval. You don't counsel them per embryo. So really what you need is to analyze these studies on a per retrieval basis to understand what the benefit is per patient. And this study started to suggest maybe there wasn't a benefit if you look at it per retrieval. So we're going to talk a little bit more about the current data, but before that, I want to introduce one more concept about Pgta, which is really important to understand the current state of Pgt data. And that topic is embryo mosaicism. So although prior studies suggested that there were low rates of embryo mosaicism, recent studies suggest a much higher rate. So embryo mosaicism was kind of glossed over in all the previous studies because basically what people thought was that on a day 3 embryo, if you take out one cell, that wasn't really representative of the embryo because there are 7 other cells and we don't know what the genetic makeup of those 7 cells are compared to the 1 cell. But by the time you get to day 5, if you take 8 to 10 cells out of that embryo, that is a very representative picture of what that embryo is going to be. And so the concept that your Trophectoderm biopsy was representative of what the embryo was going to be was pretty much thought that that was true. However, in recent years, we have begun to realize that that is not something that we can take for granted, that the difference in euploidy between the trophectoderm and the inner cell mass may be up to 35%, and that oftentimes when you do a biopsy, you have multiple cell lines in the embryo. And so when you say that the embryo is mosaic, what you're saying is that there are multiple cell lines in that embryo, and you don't really know whether that embryo is euploid or aneuploid based on your 8 to 10 cell biopsy. So when you have this doubt injected into your biopsy, now how can you reliably say that an embryo is normal or abnormal based on this result? Now you have a gray. And the question is, how do you assign these gray embryos when you're doing clinical trials? What benefit does the patient have when you take mosaic embryos into account? And that really is the crux of how you design Pgt trials to show benefit to a patient, because these embryos are a place of doubt. Do these embryos deserve to be transferred, in which case you may give some additional pregnancy success to the patient, or should they not be transferred because they may not be as good, in which case you might actually decrease chances of success for that patient. So that information is really important to understand, and it's important to understand how to counsel patients in terms of, is PGT going to increase success rates for your patient, or is it actually maybe going to decrease success rates for your patients if you exclude embryos for transfer that you may otherwise have transferred? So this is just some studies that show that mosaicism has become an extremely controversial topic within the field of IVF. So like we said, what is a mosaic embryo? So these are embryos that have multiple cell lines within the trophectoderm. So when you biopsy 8 to 10 cells, you may be getting multiple cells in your biopsy. Now, to make matters more complicated, each Pgta testing company has its own definition for what they consider euploid, aneuploid, high-level mosaic, and low-level mosaic based on their technology. So when they're doing next generation sequencing, what they're doing is they're putting all of the readouts into an algorithm, and then they're based on their algorithm, they're making a decision whether that embryo is normal or abnormal. And cells that are in the middle, they have to make a judgment call. Are those aneuploid, low-level mosaic, or high-level mosaic? So what platform you choose for your Pgta will determine your mosaic rates. There's also some data to suggest that laboratory conditions have a role in mosaicism. Some labs have higher mosaic rates than others, and that can depend on the skill of the embryologist and the laboratory culture conditions in terms of how the biopsy is performed. So current recommendations are changing as to what to do with mosaic embryos. So the trend is to transfer low-level mosaics when the abnormalities are incompatible with life. So we are specifically want to exclude trisomies 21, 18, and 13 from transfer, because if the baby does have these trisomies, then those are compatible with life, and then you may have an abnormal pregnancy. However, if you have something like a mosaic 20, 16, or something else that would likely not be compatible with life, that would be an embryo that you may want to consider transferring. However, many institutions still do not transfer high-level mosaics, but many do. And there are good data to suggest that low-level mosaics have a reasonable pregnancy rate, and there have been normal pregnancies from high-level mosaics as well. So some experts even suggest transferring aneuploid embryos in patients with no euploid embryos available. But most centers in the United States will only do this with an IRB approval. There are some places in the United States that do have IRB approval and do transfer aneuploid embryos under these studies. IRB is the institutional review board that approves research in the United States. And in general, we choose embryos that are incompatible with life for transfer if we're choosing aneuploid embryos for transfer. So this is an area of active research, and I do fully anticipate that this will change rapidly in the next few years, so stay tuned. So where are we now in terms of Pgta? So why I wanted to talk to you about mosaicism before talking about outcomes with Pgta is because I really think you cannot understand the success rates of Pgta until you understand the concept of embryo mosaicism. And that all really came to a head in this trial, the 2019 STAR trial that was published in Fertility and Sterility, and I think really surprised a lot of people because it was a randomized controlled trial that was a multi-center design, and it randomized women to Pgta or no Pgta and did not show an increased pregnancy rate with Pgta. Now, it may sound familiar to anybody who's practicing in 2007, but it's different, right? Because here we did have a technology, we have some other data showing that Pgta was successful, but yet again, we have another randomized controlled trial showing no success. But in order to understand this trial, I think we have to understand the role that embryo mosaicism played in these results. So let's go over it in more detail. So here's the study. It was called Pre-Implantation Genetic Testing for Aneuploidy versus Morphology as Selection Criteria for Single Frozen Thawed Embryos in Good Prognosis Patients, a multi-center randomized controlled trial. So what they did was they had 661 women who were randomized to Pgta versus morphology for embryo selection. So they had 330 people in the Pgta group and 331 in the control group. Now, overall, the ongoing pregnancy rate was 41% in the Pgta group and 43% in the control group. So no difference. Now, when they did subgroup analysis, they showed a higher pregnancy rate per transfer in women ages 35 to, sorry, let's just say 40. So 35 to 40. So they found a 50% pregnancy rate versus a 37% pregnancy rate. So pregnancy rates were higher in older women who had embryos to transfer. Now, just like we saw in that Cornell study, there was no difference when analyzed based on intention to treat. So when women had embryos and were biopsied, that was intention to treat. So when you analyzed it based on intention to treat, there was no difference. But when you found a euploid embryo and transferred it, women who transferred based on their ploidy status had a higher rate of success. A couple of things to note in this trial: they did single embryo transfers for all of their patients, even the ones above the age of 37. When typically in clinical practice, we would do 2 embryos if we were untested. Why was there not a higher pregnancy rate overall in the Pgta group? So a couple of things. So in the 2007 study, we attributed it to FISH and day 3 biopsy. So that's not the case anymore. So what we can say here is, okay, maybe it's a little different. So maybe there was a negative effect of the biopsy on the embryo. And the big issue in this trial was mosaicism. So this trial was conducted using next generation sequencing for the Pgta technology, but before we really understood the concept of embryo mosaicism. So any embryos that came back mosaic were excluded for transfer. So that probably excluded embryos for transfer that would have resulted in normal pregnancies had they been labeled as potential options for transfer. Now, we can't go back and change what happened in the trial. So if we had included those embryos in the trial, would we have seen an improvement in clinical pregnancy rates? We don't know. We can't go back and do that trial. But certainly, excluding those embryos for transfer seems to have potentially limited the ability of Pgta to improve success rates. Now, whether there's a potential damage of the embryo from the biopsy, we're going to talk about in a second. So the overall conclusions of the trial were that there may be a possible benefit for older women when euploid embryos are found, but again, not in the intention to treat analysis. And the benefits are likely in reducing time to pregnancy and reducing aneuploid miscarriage, not in improving overall pregnancy per retrieval cycle, because you are not changing the number of embryos that you have. And again, when you don't know what euploidy status is of the embryos, we did not see an improvement in success rates. Now, the last trial I want to show you is to answer this question: is there damage to the embryo from the biopsy? So this study was just published in 2021. This is also published by Richard Scott's group, and it was a prospective, blinded, non-selection study where they transferred embryos that had been biopsied, but they did not use the results of Pgta when transferring these embryos. So in other words, they took 2 groups of women and they biopsied their embryos and then looked at their results only after they were pregnant, comparing those to another group of women who had embryos transferred without biopsy. So the goal of the study was not to say, does using Pgt results improve pregnancy? The goal of the study was to say, does biopsying the embryo impact success rates with pregnancy? And how do our Pgt results compare to genetic testing the results that we get if the patient had a miscarriage or an abnormal result from genetic testing during pregnancy? So what they did was they did 484 single elective embryo transfers. They found no difference in ongoing pregnancy rates between biopsied and non-biopsied embryos. And in terms of their results, they did not find any aneuploid embryos that resulted in ongoing pregnancies. Now, they restricted how they defined aneuploid embryos to whole chromosome aneuploidies. Okay, they were very specific. They said that no euploid embryos resulted in miscarriages that were later found to be aneuploid. However, they did find segmental aneuploidies and mosaic aneuploidies that did result in ongoing pregnancies. So 68% of mosaic embryos resulted in ongoing pregnancies, and 30% of embryos that had segmental aneuploidies, meaning the whole chromosome wasn't aneuploid, but just a part of the chromosome was aneuploided, resulted in ongoing pregnancies, which is a lot. So when they say that there was no aneuploidies that resulted in pregnancies, there's a caveat there, right? Because mosaic embryos did and segmental aneuploidies did. So the conclusion of the study was that there was no apparent impact of the biopsy in the embryo. But I think the bigger conclusion of the study is that you have to be very careful when you do Pgta biopsies, how you define aneuploidy, because to a patient, any abnormal result is abnormal. But in order for Pgta to be effective, we have to understand how we define aneuploidy and what the role of these lesser aneuploidies, such as mosaicism and what we're now calling segmental aneuploidies, are, and how we're going to counsel our patients to be sure they understand it. Because if you exclude these embryos for transfer, you are certainly going to reduce your ability to have your patient get pregnant from those embryos. So what are our current conclusions from Pgta? So no randomized controlled trial has shown a benefit of Pgta for younger women. The prior randomized controlled trial that showed improved success rate with qPCR technology, it used this qPCR technology that was less sensitive for mosaic embryos, and it randomized patients based on having 2 good quality embryos. So if Pgta is chosen, careful counseling regarding mosaicism and segmental chromosome aneuploidies must be provided, as I discussed, and having a genetic counselor that can really explain to patients what these aneuploidies mean is very important. And mosaic embryos may be eligible for transfer with proper counseling. So what conclusions overall can we draw about Pgta? So Pgta and Pgtm are both useful tools for embryo testing. Obviously Pgtm for single gene disorders and Pgta for aneuploid screening. Day 5 biopsies are now preferred to reduce the error rate. There are multiple different technologies. The possibility of mosaicism still exists. Pgta does not replace prenatal aneuploid screening. So even though we think it's fairly accurate, we do think there's probably about a 2% error rate, that trial notwithstanding. So we do recommend that patients who have Pgta still consider genetic testing of their embryo while they're pregnant if they want it. Pgta right now in the United States is not routinely recommended to patients under the age of 35. Individualized counseling is recommended for patients over the age of 35. As there may be benefits for time to pregnancy and embryo selection, and Pgta certainly can be useful for improving elective single embryo transfer, because we only transfer 1 euploid embryo as opposed to multiple untested embryos. And we know that multiple gestation is not a good outcome for many patients. So in that respect, Pgta can be useful for improving outcomes for patients, particularly patients for whom twins would be very high risk. So overall conclusions, and I thank you for your attention. There is a trend towards increasing use of freeze-off cycles in Pgta in the United States, and I'm curious again to hear what the trends are in Egypt. There are mixed data for both. There is an increased risk of preeclampsia and macrosomia with programmed FET cycles. So therefore, there are new trends emerging for natural and stimulated FETs. This is again brand new, and we need more data from RCTs. The data regarding Pgta is complicated, and individualized counseling is needed. Again, Pgta right now is not routinely recommended for those under the age of 35. And the overall trend in ART is for elective single embryo transfer. So thank you for your attention. I look forward to taking your questions, and it's really been a pleasure speaking with you today.
Well, thank you very much, Rachel, for a great talk and very comprehensive overview of two controversial topics. So, Professor Tarek, are you ready for the questions?
Yes, thank you very much, Rachel. It was an excellent presentation, and I enjoyed it very much. Touches very two controversial issues, and we do have some questions for you. Can I start?
Sure.
Okay. First question. You mentioned embryo transfer at day 3 or 5, either cleavage stage or blastocyst. What about day 4?
You know, that's an excellent question. So we routinely don't do day 4 transfer. And the reason for that is, you know, you can do a day 3 transfer because at that stage you have some guidance in terms of embryo selection, right? The embryo is either 8 cells, ideally 7 to 9 cells. You look at fragmentation, or you can do day 5 to see if the embryo has really made it to the blastocyst stage. But day 4 doesn't necessarily give you a lot more in terms of embryo selection, because at the morula stage, which hopefully the embryo is at day 4, there's not that much you can do for embryo selection, because once the embryo is compacted, you really can't see much morphologically in the embryo. So, you know, if you're thinking about extended culture as a means of embryo selection, day 4 doesn't necessarily help you with embryo selection because the morphologic assessment of the embryo is fairly limited on day 4.
Related to this question, do you have any data about extended culture for day 6 or 7 embryo transfer?
Oh, excellent question. So, you know, extended culture is a trend. I probably should have added that to my slides too. It's a brand new trend in IVF. So, you know, there are embryos that will make it to the blastocyst stage on day 6 or day 7 that will have not made it to blastocyst on day 5. Now, those embryos, you can potentially transfer on day 6. However, the data is suggesting that the endometrium is probably going to be slightly asynchronous or desynchronous from the embryo if you do a day 6 and certainly a day 7 transfer, because now you have an embryo that had to catch up, right? Because the embryo is either a day or 2 days different than where it should be developmentally, but the endometrium has continued to develop. So you're probably better off freezing those embryos on day 6 or day 7 if they qualify, and then transferring that embryo in a frozen cycle on the equivalent of day 5 of progesterone exposure, so that your endometrium and your embryo are at the same stage of development to maximize success rates for that embryo. Now, occasionally I have done day 6 transfers and I have had successes. So it's not you can't do it. But in terms of maximizing success rates for your patients, probably the ideal is to freeze the embryo so that you can maximize endometrial embryo synchrony.
Okay, and again, related to this, what would you do if you don't find any embryos on day 5 in the blastocyst stage? If they are still in cleavage stage, would you transfer them anyway, or you would culture them and check day 6 and day 7 and then freeze them?
You know, that's an excellent question. I wish it didn't happen, but unfortunately it does happen that we have cleavage stage embryos at day 5. We do see it, I would say, for certain situations like severe malefactor. I do see embryo arrest, you know, oocyte quality issues, or, you know, poor embryo development that we don't necessarily have an explanation for. So we do recommend culturing those embryos for till day 7. If the embryo is still at the cleavage stage on day 7, we do not freeze them, we discard them. But that is a very unfortunate situation, but we do not see reproductive potential of the embryos if they have not made it to blastocyst by day 7.
So in day 7, you would, if they do not reach the blastocyst, you wouldn't transfer and you wouldn't freeze.
Right.
So this means that the patient lost everything.
Correct. It's very sad. I mean, that's a really heartbreaking situation, but that is what we do. We do not transfer and we do not freeze.
Okay. The next question is, you mentioned that fresh embryo transfer babies are having low birth weight. And you showed that the difference is only 200 grams. And even in those randomized, controlled, nice trials in the New England Journal of Medicine, the mean weight is more than 3 kilograms. So do you think that the difference warrants the extra cost and the extra effort and mental health for freeze all? These are only 200 grams.
That's an excellent question. So I would say there are two things that I would say to that question. So first of all, excellent question, and thank you for paying attention. So thank you, because then you actually paid attention to the details. So I appreciate that. But yes, it is important to note the mean weight of the babies was not that different. And you might say that 200 grams is really not clinically different, right? So overall, babies are still healthy following fresh transfer, and a difference of 200 grams is not clinically significant, and that baby should grow up and be fine. So overall, babies born following fresh embryo transfer are healthy, and most women will do fine following fresh embryo transfer. So I would say, yes, overall, patients do fine following fresh embryo transfer, and even a small difference in weight should not be concerning. What is concerning is the higher rate of small for gestational age that we see following fresh embryo transfer and the higher rate of preeclampsia. So if there's a higher rate of preeclampsia and a higher rate of small for gestational age, it's those smaller group of women that are at risk. Now, here's the problem. Is freeze-all the alternative? Because what I just showed you in the data is that there are some risks from frozen embryo transfer too. So if I could tell you that, you do a freeze-all and the pregnancy would not be at risk of preeclampsia and would not be at risk of growth issues, then I would say, yes, it'd be worth their time and expense. But I can't say that because I don't know what the best outcome is. Because if I tell you to do a freeze-all cycle and then you do a programmed FET cycle, that patient actually may be at higher risk of preeclampsia. So I don't know for sure that doing a freeze-all cycle is in the best interest of your patient. So right now, I would say we don't know what the best thing is. So in general, I say that make your clinical decision based on what you think is in the best interest of your patient from a clinical setting. What's going to give her the best chances of getting pregnant and what's going to give her the best chances of not having ovarian hyperstimulation syndrome. That's how I make my decisions, because I don't know yet. I don't know yet what the data is going to show. Maybe in 5 years we'll know, but because I don't know yet which is the best, fresh versus frozen, for optimizing neonatal outcomes, I don't make my decision based on neonatal outcomes. I make my decision based on optimizing success rates. So if the patient has a very, very high estrogen level and I'm concerned about ovarian hyperstimulation, that's when I recommend a freeze-all because I don't want her to get OHSS. Or if she has an elevated progesterone level on the day of trigger and I think that she might have a decreased success rate, that's when I freeze all. But I don't freeze all to try to optimize neonatal outcomes because I don't know what the best neonatal outcomes are going to be, because frozen embryo transfer also has negative impacts, as we saw.
Yes, thank you. The next question is, you mentioned the large for gestation age in frozen embryo transfer. Again, how much was the difference in the birth weight? I mean, in the fresh embryo transfer, it was about 100 grams. Are there any data about the difference between fresh and frozen?
Yeah, it's on the same ballpark. I mean, it's only a few 100-gram difference on average. So these are not significant differences in terms of the average. And then in terms of the rate of large for gestational age, I would say most studies find that the rate of large for gestational age is somewhere on the ballpark of 6 to 8%, maybe 10%, but it's small. I mean, it's not overwhelmingly high.
The next question is, are there any studies about the long-term safety of children exposed to Pgta?
Oh, excellent.
Or Pgta?
Yeah, okay, excellent question. This is an area of active research. So One thing that I will say about that is this is something that is near and dear to my heart. So I'm actually studying this in mice. So I can't translate mice to humans. So I don't want to jump to any conclusions. But what I can tell you about human data is that we have not seen any impact on the children so far. Okay, so what we have done, we have studied, actually I have studied this myself too in large databases. We have not seen any differences in neonatal outcomes when you look at children who are born following Pgta biopsy. So one study that I did, which we have not yet published, but we're almost there, we're going to submit the manuscript hopefully really soon, is that we looked at cycles where they biopsied embryos and didn't biopsy embryos and then transferred fresh and looked at the differences in neonatal outcomes of those children. We did not see any differences in birth weight. So I don't think that the biopsy itself in humans seems to have an impact on birth weight. One thing is, this has been found in several observational trials. So this is something to be on the lookout for. Again, not randomized controlled trials. So again, my benchmark for saying something is a true finding is randomized controlled trials, and then if it can be replicated in animal models. But there have been several observational trials that have shown an increased rate of hypertensive disorders of pregnancy, so preeclampsia, in cycles associated with trophectoderm biopsy or embryo biopsy. So it does seem that embryos that have been biopsied, we're beginning to see an association potentially with hypertensive disorders of pregnancy like preeclampsia. Now you might say, well, maybe that's just the same result that we're seeing in programmed frozen cycles, right? Like maybe all the patients are getting PGT are also getting frozen transfer. So that's why the association is with PGT. But they've isolated the cycles that have had the PGT separate from the freezing process, like those have been transferred fresh or those have been transferred in other types of frozen cycles, and they still see that association with biopsy and hypertensive disorders of pregnancy. So that is brand new. So I cannot tell you for sure that that's an association, but that is something that we're keeping our eye on.
So this means that up till now, women with elevated E2 level, women with hormonal prepared frozen embryo transfer, and women with PGT all have higher risk of preeclampsia.
That's correct.
That's correct. The next question is, when you are tired of questions, let me know so that I can stop.
I can make a comment about preeclampsia specifically here, just to throw a few things for people to think about. I think now we have means to start screen for preeclampsia early on, all the way up to down to the first trimester. And I mentioned a few items of that in my lecture, which was the first lecture in this series. And the second one is, yes, you know the risk group. Sorry, Rachel, to interrupt. The risk group for preeclampsia, we have now evidence that low-dose aspirin can prevent preeclampsia in those patients. So I would treat those patients who are at high risk of preeclampsia early on with low-dose aspirin. And in addition to that, I would screen them early on during the first trimester to try to treat early or intervene early to prevent the consequences. I'm not sure if Rachel has anything to comment about that.
I 100% agree. And basically, I treat every patient of mine who is undergoing a frozen embryo transfer, like a programmed frozen embryo transfer, again, because of this data as potentially having a higher risk of preeclampsia. So I tell them to take aspirin during pregnancy for that reason and, screen them early. But again, I don't know that I would change clinical practice yet. I don't want to, I don't want to be overly alarmist, because we don't know that not every patient is going to get these. These are small associations, an increased risk. Everybody, you can come up with an increased risk of preeclampsia for a lot of different groups. Any older women have an increased risk of preeclampsia. People with underlying diabetes have an increased risk of preeclampsia. Overweight women have an increased risk of preeclampsia. So these are a lot of patients that we're already treating in our IVF. What?
Multiple pregnancy.
Multiple pregnancy, exactly. So, I don't think that, these risks should be a reason not to treat patients and not to do what we're doing if we think it's in their best interest. So I do think that we need to await further data, and it hasn't necessarily changed practice here. And especially the risk of biopsy and preeclampsia is super early. And again, it's observational. We don't have randomized controlled trials. So I would not recommend a change in practice based on that yet. I think it's too premature. But I do think I agree that, a baby aspirin, screening women early is not a bad idea. But I just think that this is very early data. I like to look at the research and kind of see what's going on because I'm a researcher. I like to be interested in knowing the etiology and mechanism. But I don't think that as practitioners, we should be, not doing PGT because of these concerns at this juncture.
Okay. The next question is, what is the risk of damage to the blastocyst in Pgt in experienced hand?
Yeah, so that's an excellent question. And I think the key to that answer is the question, experienced hands. So as you saw in that last study that I presented, I would say that Richard Scott's group, which is based in New Jersey, and they've also partnered with IVI, so they're kind of like a very large practice now. They are probably one of the world leaders in their experience with PGT. Now, in their hands, in their study, they did not see any difference in success rates from the biopsy versus the non-biopsy group. So they did not see any damage to the embryo in their study. So I would say in experienced hands, there's probably little to no damage from trophectoderm biopsy. But I would say most of us are not that group. So most of us probably are not as experienced. And I would look to the other trial, the STAR trial, to say there was no improvement in PGT in that trial. And I would say that probably some of that no difference. In other words, why was there no difference in the younger patients? Probably some of that may have been due to damage from the biopsy. So I don't know that we can quantitate that. But I think that there probably are differences based on lab. But I think that in experienced hands, there's probably very little damage.
But you have to put a figure for the patient, which has only 2 blastocysts. She may lose one of them, or she may lose both of them, because as you know, even during the procedure of ICSI itself, you can lose an egg. And in fragile Oolemma syndrome, you can find the same thing in the blastocyst. So if the embryo can withstand the puncture of the ICSI needle, it might collapse with the second puncture of the trophectoderm, even if it is by laser.
Exactly. So that's why I think it's a little misleading, the data coming from Richard Scott's group, because, they're so good at PGT, I don't know that can really translate to other groups. So, we don't have the data to tell us what the damage is to embryos in other centers. All we can say is, actually Richard Paulson is, just gave a really interesting webinar on Pgta, and he's done some interesting math where he says, okay, what would you expect the aneuploidy rate to be, in the control group versus in the Pgta group, and therefore what would you expect the rate of implantation to be? And he basically calculated based on that, a significant loss rate for the Pgta embryos, because they did not have any, there was about it was only like less than 60% implantation rate, successful live birth rate in the Pgta group, but you're transferring 100% normal embryos. So why did those embryos not implant? Some of it may be uterine factors, but some of it may have been because of damage to the embryo from the biopsy. So I do think that there is some caveats to Pgta, and definitely would not recommend it universal application before the labs have been validated. Now, one thing too to understand about Pgta is, I think I mentioned this, but it's really important. Euploidy, aneuploidy, and mosaic rates vary by lab. And if your lab does not have good euploidy rates, you probably shouldn't be doing PGT for your patients, because the euploidy rates you're getting and the mosaic rates you're getting may not be representative of the actual reproductive potential of your embryos. So in that same webinar, I thought it was really great. I don't know if any of you guys have access to it, but Eric Foreman, who also was trained at Richard Scott's group, said, if you don't have at least a 60% euploidy rate in patients under the age of 35, you're probably not optimizing PGT for your embryos. So, that's the benchmark you should look for. And if not, then probably PGT isn't great. Now, I don't know that even in my lab, I even have that number, because we don't generally do PGT for patients under the age of 35. Because we think that we probably aren't going to be benefiting our patients from doing it. So we generally don't do PGT for that age group.
Okay, someone is asking about what is the cost of Pgta in USA.
Excellent question. Yeah, excellent question. So it really varies by center. I can only speak for my center. I know the costs are higher on the coast. I'm in the Midwest. Things are a little cheaper where we are in Cleveland. But for us, it costs about $1,500 to do the biopsy. And then the Pgta companies charge their own costs per embryo. So overall, for us, it costs about $3,000 to $4,000 to do Pgta. I don't know if, in Canada, it's different. But I know that in some places it can be closer to 5,000 or 6,000.
It's 6,000 Canadian on top of the cost of the IVF cycle in Canada.
Is it covered by insurance?
No, zero coverage in British Columbia. So the patient has to come up with the entire cost, including medications.
The assisted conception is not covered by insurance?
No, it's not in BC, not in BC. So patients
as
has
well
really
as in Egypt
from the beginning.
Yeah,
okay.
and for us in Ohio, insurance coverage is varied. So some companies cover it, some don't. But Pgta is usually not covered.
Yeah, if the patient is working for Google or for Microsoft, then she will be covered. But it depends on her own personal insurance. But there's no universal agenda. But kind of trend, the majority of the patients has to pay out of pocket here.
Okay, the next question is, if you are going to transfer mosaic or aneuploid embryos, is there a percentage of healthy live births?
Excellent question. So it all depends on what the actual abnormality is. So I found it very interesting. The most recent study, the last one I presented to you, Teagues et al., that was published in 2021 in Fertility and Sterility, they showed a 68% ongoing pregnancy and live birth rate for mosaic embryos.
60%?
68%.
68%.
Previous studies were lower. So previous studies suggested 30 to 40% success with mosaic embryos.
So what is the success of euploid embryos would be?
So for
the mosaic or the aneuploid is 68. What would be the results of their euploid embryos?
Right. Well, they had very high success rates, as you saw. Their success rates for euploid embryos were like in the 80s. Yeah, so they had high success rates and they're good prognosis.
Well, I have a comment about that because Gary Nakuda from our division was a site, was on the STAR trial. And that were really a great group from different clinics all over the world. And they reported 41%. So I'm curious to ask you, Rachel, what is the current pregnancy rate in your center when it comes to Pgta overall and for the good prognosis patients and for patients above?
Yeah, I mean, I think I agree with you. I think it's really challenging to read Richard Scott's data and see how it applies to all of us, because our success rates with Pgta are probably in the order of like 58%, maybe like 58, 60% with Pgta embryos. So in the 60% range is what I would say.
Yeah, the other struggle I have actually with secondary analysis of the STAR trial for patients above the age of 35. So they reported a benefit with patients who have embryos that survived and transferred, not intention to treat. So how would you know that ahead of time, knowing that a lot of those patients are poor responders to start with? You're not very certain about getting blastocysts to start with for a good number of them. So how would you handle that in the counseling process when you tell them that there could be a potential benefit? However, so what comes after however?
Oh, that's an excellent question. And I think that right now we are in this really complicated place of PGTA. And that's why I wanted to bring this to you guys today, because, you know, ART is never simple, right? We are really complicated, but I think fresh versus frozen is not straightforward, and PGT is not straightforward. And I think that more than ever, I have very difficult conversations with my patients regarding PGTA. I don't know about you. I don't have a lot of time to spend with each patient for IVF. I have about an hour. I have to go through all of IVF counseling, but I would wish I could have an hour just to talk about PGTA, because it is a very complicated topic. So what I tell them is, it all depends on what your goals are. You know, if your goal is to maximize your pregnancy for your cycle, I don't know that I'd recommend PGTA, because there is the potential to discard embryos that you could use. So if you're the kind of patient, which I have a lot of, who does not have a lot of money and they're only going to do one retrieval, and they may only get a few embryos, and if they want to transfer those embryos no matter what, I would not recommend PGTA, because I don't think it's going to help them improve their success rates. If they're the kind of patient who thinks that having a miscarriage is the worst result that they can think of, and that they may want to do multiple cycles, you know, to get to their pregnancy faster, I think PGTA can be beneficial, because it can help them, you know, optimize knowing how, you know, when to transfer based on the embryos they have, or it can help us select one embryo for transfer. But overall, I don't encourage my patients to do PGTA if they are the kind of patient that's like, I'm only going to do one cycle and these are all the embryos they have, because I don't think that improves outcomes for that cycle. I think it just helps you know which embryos to transfer first. The one thing that I tell patients is, if we are the kind of patient who gets a lot of embryos and you're 39 years old or 40 years old, then we may want to consider PGTA, because how do we know which embryo to put back if you have, you know, 7 embryos? You know, that's the question that we have. And so sometimes we do a tentative plan where we say, okay, we're going to consider PGTA, but we're not going to make a final decision until we actually see how many blastocysts we have. It's a complicated counseling, but we do sometimes make that plan, and then we only do the biopsy if we have, you know, greater than, say, 4 embryos, because otherwise the patient may be willing to do 2 embryo transfers of 2 embryos each. And then maybe financially they'll come out just the same as doing PGTA. I don't know how you do it, but that's where we are right now in terms of our counseling.
I very much use the same approach, because I see a lot of recurrent pregnancy loss patients, and you know, there's a lot of commercialization, so the patients come and bring it to discussion, and sometimes you have to schedule a whole appointment to talk about that, like what you said. So we put a lot of factors there about their future plans, and how much they are ready to invest in this, and what if they end up with one blastocyst, what they want to do with that. So I just tell them the only known benefits here probably is shorter time to pregnancy, which is in the recurrent pregnancy loss situation is not a problem, because they get pregnant very soon. And the second is maybe decreasing the risk of miscarriage, because we know that we are not going to transfer any aneuploid embryos in your case. Hence, I say, well, we don't have a clear data that it could be really improving your life birth rate. There is no guarantee that you will get a baby out of this. So with that, if you are ready to invest and do you want to you're prepared to do more than one cycle, then it would be beneficial. It may be beneficial to you.
The cost
I agree.
the cost of PGT and biopsy and PGT itself is more than the cost of the IVF cycle. So
Oh, wow.
the cost is higher. So we'll think about it. Next question is a technical one. What is the best time for embryo transfer after thawing?
Oh, excellent
Is it
question.
immediately 2 hours, 12 hours, 6 hours? What is the best time?
Yeah, that's an excellent question. So for our lab, we actually thaw in the morning, like first thing in the morning, and then we usually transfer late morning. So we usually let the embryo sit for a couple hours prior to thaw to allow for re-expansion. But because we do freeze usually later in the day on day 5, so we usually already freeze the embryo at the expanded blastocyst stage. We find that just a few hours to re-expand after the thaw is sufficient prior to transfer. So we don't let them sit overnight. Because we want them to still be at that same stage of development. So we usually just give them maybe 2 to 3 hours to expand after the thaw, and then we transfer.
This is about the blastocyst, yes?
Correct, yeah.
Okay, what about cleavage stage embryos?
So the same, we just let them survive the thaw and then we transfer. So we don't let them sit. Now, we do have some patients that want to transfer cleavage at blastocyst because we used to thaw a lot at cleavage. So we do have some patients that now are thawing their cleavage and then grow to blastocyst and then transfer at blastocyst. But that, to me, that's only patients that have multiple. Like, the only reason to do that, in my opinion, is if you have embryo selection, right? You only transfer up the blastocyst stage to improve embryo selection. So for patients that have multiple embryos frozen at the cleavage stage, who want to, who don't know which embryo to transfer, they can then, they give them the option of thawing their embryos to the blastocyst stage for transfer. But if they only have, 2 embryos at cleavage and they're willing to transfer both, then I would just thaw and transfer.
Okay, the next question is not very relevant to the your topic, but is there a role of recombinant LH in IVF? And if yes, what would be the indication?
Oh, that's an excellent question. I think this is always something that comes up because, recombinant FSH has become so popular, and then recombinant LH was developed and taken off the market because, we used, urinary LH and then HCG as the option. So I think that we do know that LH during stimulation is very important for oocyte competence and to have a better egg quality, leading to better embryo quality. So that combination protocols utilizing FSH together with some form of LH activity, whether that's something like human menopausal gonadotropin or a low dose HCG, we do see improved pregnancy outcomes compared to protocols that use just FSH. There's been Cochrane reviews, meta-analysis that have shown that. Now, whether recombinant LH would be better than the low-dose HCG that we use, I don't know. I mean, the benefit of recombinant is that you can really titrate the dose very specifically. I think that there have been issues historically with the amount of HCG that we see in, Menopur or human menopausal gonadotropin. But recombinant LH is also is very expensive. And we don't know if, the whatever isoform of LH that we choose would be as beneficial as the LH that naturally occurs in urine, or, the HCG because its half-life is so long and effective. So the answer is, I don't know. We do know that LH is important. Specifically recombinant LH, I don't feel like I have the expertise to comment on. But I do think that, as always in IVF, studies would be helpful.
Okay, if you get at any moment, let me know and we can stop. I have 2 questions.
I'm fine to keep going.
Okay. Next question is, your data or the data that you have shown, that you showed us about fresh versus frozen embryo transfer. Are the results equal in young and elderly women, normal versus poor responders? And what would you think is better for each, the normal responder and the poor responder?
So that is an excellent question. So the randomized control trials that I showed you did not necessarily specify old versus young, although we do have normal versus high responders because the PCOS patients were high responders. But what I can tell you is that observational data suggests that older women and poor responders have a higher rate of premature luteinization of their follicles and a higher rate of elevated progesterone levels at the time of HCG trigger, which has been associated with decreased success with fresh transfers. So from a neonatal outcome perspective, I don't have the data except to say that higher estradiol levels are associated more significantly with small for gestational age and preeclampsia. So if you think about that, older women and poor responders would be expected to have a lower response to stimulation and would not be expected to have those same neonatal outcomes as a result of fresh transfer. However, older women and poor responders also would be expected to have lower success with fresh transfer because of this issue with premature luteinization. But that is something that you could triage by checking a progesterone level the day of HCG trigger, or you could look at your own internal data. So, we looked at our own internal data at UH, and we did see a trend towards decreasing success rates in older women with fresh transfer. So we do preferentially recommend Freezol for some women above the age of 38 for that reason. But that is something that you could look at internally to see if that's consistent in your data. And if that was the case, then you may think about recommending Freezol just purely for clinical reasons, not because of neonatal outcome reasons, because that would be expected to be associated with estradiol levels.
Would you think that giving Freezol in the presence of low number of embryos would be something successful? I mean, poor responders wouldn't bring a lot of eggs, and hence they will not bring a lot of blastocysts.
Exactly, and that's why you may consider, you may want to consider doing day 3 fresh transfers in those patients.
That's right. Yes.
Yeah, exactly. So there's another thing to think about too, is that endometrial embryo dysynchrony may be different in day 3 versus day 5 transfer. So that, in an older patient, there is probably some benefit to doing a day 3 fresh transfer if you have low embryo yield, because again, the benefit of day 5 transfer is embryo selection. If you have very few embryos to choose, you're not going to benefit from taking them to day 5 because there's no embryos to select.
That's
and in an older patient, you are going to probably want to transfer, 3 embryos. Then if all you have is 3 embryos, then you're not going to gain anything by taking them to the day 5 transfer.
Okay.
And you might benefit from doing the transfer earlier because then the embryo has time to culture in the uterus.
So now we come to our last questions. Last question. Are there any current guidelines or recommendations for Pgta in USA?
So, interesting about USA, we are a nation that does not like to do things in the collective. We like to have individual choices and decisions. So there are really no national guidelines for Pgta. Now, that is something that might happen in the future. Obviously, we do have guidelines for the number of embryos to transfer. That is something that the American Society for Reproductive Medicine developed, and that has really helped to decrease the number of multiple gestations in the United States. But we do not have guidelines for Pgta. It is an area of significant controversy, and the practice really varies by practice. So there are no national guidelines.
And that is where we stepped in. Canadian Fertility Andrology Society just released their guideline for Pgta, and I'm happy to share it with.
I would love to hear it. We could probably use some help in America too.
Exactly. So we have a Canadian guideline for Pgta. Well, it's not very different from what Rachel summarized in her excellent lecture. but I'm happy to share it with you.
Okay, thank you very much. Thank you, Rachel, for your time, for your effort, for your excellent presentation, and for patience with our questions.